Assalamu alaikum. Good evening. I'm going to basically be discussing the Sanofi Solimix study. I have no disclosures. The objective of my presentation is going to be discussing the challenges regarding premixed insulin, exploring the range of evidence for fixed ratio combination, insulin glargine in combination with lixisenatide, iglar-lixi, in terms of better efficacy and safety versus premixed insulin, and conclusions. So as we all know, guidelines for injectable therapy are quite clear. Due to the progressive nature of type 2 diabetes, many individuals not controlled with oral anti-diabetic drugs will require advancement to injectable therapy. So we have initial injectable therapy in the form of GLP-1 receptor agonist, basal insulin, combination injectable therapy, premixed insulin. EASD generally recommend GLP receptor agonist as a first injectable option. Basal insulin or combined injectable therapy can also be considered as first injectable therapy depending on patient profiles. NICE recommend premixed insulin as an initial injectable in those with HbA1c of more than 9%. As we all know, intensification of injectable therapy is in most instances required. And then in that case, we combine basal insulin with GLP-1 receptor agonist or vice versa. Fixed ratio combinations of basal insulin plus GLP-1 receptor agonist, basal plus prandial insulin, that is basal plus and basal bolus regimens, and premixed insulins. Premixed insulins are efficacious at the expense of weight gain and hypoglycemia risk versus basal insulins, as we all are aware. People with type 2 diabetes, uncontrolled on basal insulin, who switch to premixed insulin in randomized controlled trials, we can clearly see HbA1c reductions after 24 or 26 weeks, anywhere from 0.8 to 1.9%, reaching a p-value of less than 0.01, but this comes at an expense, which is greater body weight increase. And we can clearly see with premixed insulins, the weight gain could be anywhere from 0.8 kilogram to 5.4 kilograms, and with basal insulins from 0.1 kilogram to 3.5 kilograms. And not only that, it is again associated with increased hypoglycemia risk, premixed insulin more so in terms of 3.4 to 8.2 events patient per year versus basal insulin from 0.7 to 5.4 events patients per year. I'll be talking about the UK Thin database, a retrospective UK cohort study, which looked at the effectiveness of premixed insulin to achieve glycemic control in type 2 diabetes. Adults with type 2 diabetes, HbA1c of more than 9%, inadequately controlled on more than or equal to 2 oral anti-diabetic drugs. They were switched from OADs to premixed insulin, 974 eligible participants. The primary outcome was probability and incidence of achieving glycemic control, that is HbA1c of less than 7.5% over 24 months post-premixed insulin initiation. Sensitivity analysis included incidence of improving glycemic control, that's more than 1% HbA1c decrease or more than 2% HbA1c decrease over 24 months post-premixed insulin initiation. The key results were as follows. Probability of achieving glycemic control HbA1c less than 7.5% following premix initiation was low, less than 20%. It was highest at 3 to 6 months, 18.2%, plateaued after 15 to 24 months. Incidence of achieving HbA1c of less than 7.5% or improving more than 1% or more than 2% HbA1c decrease from baseline glycemic control following premix initiation plateaued after 24 months. IDNPS observational study results and conclusions. We can clearly see that the HbA1c was 8.4% with basal compared to 8.8% with the premix insulin. Proportion of patients with HbA1c less than 7% was 17.5 in patients who received premix insulin versus 20.8% those who received basal insulin. More patients experienced hypoglycemia in the premix insulin, 32.5% versus 19.8% in the basal insulin. In conclusion, approximately 80% of adults with type 2 diabetes in the IDMPS database treated with premixed or basal insulin did not achieve adequate glycemic control. The incidence of hypoglycemia was high, indicating there is an unmet medical need to improve clinical outcomes in IDMPS countries. Barriers to optimal use of insulin, as you all are aware: fear of hypoglycemia, fear of weight gain, multiple daily injections, complex regimen. And these are further compounded by the use of premix insulins. So greater risk of hypoglycemia versus basal insulin, greater risk of weight gain, multiple daily injections, increased self-monitoring requirements. Therefore, the greater likelihood of barriers to optimal use of premix insulin may suggest that the efficacy observed in randomized controlled trials is difficult to achieve in real-world practice. Advancing therapy in suboptimally controlled basal insulin-treated type 2 diabetes, clinical outcomes with iGlarlixy versus premix by ASP30 in the Solimix randomized controlled trial. Population included adults with type 2 diabetes, failed to reach glycemic control with basal insulin plus 1 or 2 oral anti-diabetic drugs. Head-to-head randomized controlled trial comparing iGlarlixy versus by a premix insulin by ASP30, the Solimix study. It was an open-label, randomized, active-controlled, 26-week parallel group multi-center study comparing efficacy and safety of iGlarlixy versus premix insulin analog by ASP30. This study will be the first to assess the comparative efficacy and safety of advancing basal insulin therapy by switching to twice-daily premix insulin regimen or by switching to a simpler once-daily fixed-ratio combination such as iGlarlixy. This was the study design: adults having type 2 diabetes above the age of 18 years, inadequately controlled by basal insulin, combined with metformin plus minus SGLT2 inhibitors, HbA1c of more than 7.5% and less than 10%. 443 patients were randomized to receiving iGlarlixy once daily, and 444 patients were randomized to receiving by ASP7030 twice daily. And it was studied till week 26. Two primary efficacy endpoints were looked at: non-inferiority of iGlarlixy to by ASP30 in HbA1c reduction from baseline to week 26, non-inferiority margin of 0.3%, superiority of iGlarlixy to by ASP30 in body weight change from baseline to week 26. Key secondary efficacy endpoints: superiority of iGlarlixy versus by ASP30 in the proportion of participants reaching HbA1c target less than 7% without weight gain at week 26, proportion of participants reaching HbA1c target less than 7% without weight gain at week 26 and without hypoglycemia less than 70 milligram per deciliter during the treatment period, HbA1c reduction from baseline to week 26. Other secondary efficacy endpoints that were looked at was the proportion of participants reaching HbA1c target less than 7% at week 26, change in total insulin dose from baseline to week 26, change in fasting plasma glucose from baseline to week 26. Safety endpoint: hypoglycemia was thoroughly studied. It included, but not limited to, any hypoglycemic event, ADA level 1, blood glucose less than 70 milligram per deciliter and more than 54 milligram per deciliter, ADA level 2, blood glucose of less than 54 milligram per deciliter, ADA level 3, severe hypoglycemia requiring assistance. Serious adverse events of special interest were looked into as well. Patient-reported outcomes was also looked at. Treatment-related impact measure diabetes, TRIM-D scores, patient and physician rated global treatment effectiveness evaluation, GTEE scores. We'll just look into the baseline characteristics of the Solimix study. So if you look at the two groups, the iGlarlixy group and the by ASP30 group, they were well matched. Age was 59.8 years. Female, there was a very good representation of females, 50%. BMI of 30. duration of type 2 diabetes of 13 years, HbA1c 8.6%, average basal insulin daily dose was 0.4 unit per kilogram. That means they were pretty much on adequate dose of basal insulin. SGLT2 use at screening was 23%. So very well matched groups. If you look at the background OAD use percentage of participants, as expected, 76% were on metformin alone, 23% were on metformin plus SGLT2 inhibitors, less than 1% on metformin plus other, and SGLT2 inhibitors alone. If you look at the prior basal insulin at baseline, from 42 to 49% were on insulin glargine 100 unit per ml, 22% were insulin glargine U300, 23% were on NPS, 7% were on insulin detamers, and 4% were on insulin degludec. Both primary efficacy endpoints were met. So iglor-lixi was non-inferior to BIASP 30 in change in HbA1c from baseline to week 26. Just to remind you, the mean the baseline HbA1c in the two groups, the iglor-lixi and the BIASP 30, was 8.6%. At week 26, the iglor-lixi group achieved HbA1c of 7.3%, and the BIASP 30 group achieved HbA1c of 7.5%. The LS mean change in HbA1c from baseline to week 26% was 1.3% in the iglor-lixi group versus 1.1% in the BIASP 30, resulting in an LS mean difference of 0.2, thereby achieving non-inferiority and superiority with a p-value of less than 0.001. Iglor-lixi was superior to BIASP 30 in change in body weight from baseline to week 26. Just to remind you, the baseline body weight in iglor-lixi group was 80.7, in the BIASP 82.2. At week 26, the weight in the iglor-lixi was 80.2 versus 83.4 kilogram in the BIASP 30. Therefore, LS mean change in body weight from baseline to week 26 was 0.7 kilogram reduction in weight in the iglor-lixi group versus a gain of 1.2 kilogram in the BIASP 30, resulting in a LS mean difference of 1.9, thereby achieving superiority. HbA1c target achievement without weight gain and without hypoglycemia was significantly greater with iglor-lixi versus BIASP 30. So significantly greater proportion of participants in the iglor-lixi group compared with the BIASP 30 group achieved HbA1c of less than 7% without weight gain at week 26, 27.5% in the iglor-lixi group versus 12.4% in the BIASP 30. HbA1c of less than 7% without weight gain at week 26 and without hypoglycemia during the treatment period, 19.4% in the iglor-lixi group versus 7% in the BIASP 30 group. HbA1c of less than 7% alone, 42.2% in the iglor-lixi group versus 31.8% in the BIASP 30 group. Greater reductions in fasting plasma glucose and lesser increases in total insulin daily dose were observed in iglor-lixi versus BIASP 30. So there was a 1.07 LS reduction in the fasting plasma glucose in the iglor-lixi group versus 0.16 millimole per liter reduction in the fasting plasma glucose in the BIASP 30 arm, resulting in an LS mean difference of 0.91. And in terms of total insulin daily dose, there was an increase of 10.6 units in the iglor-lixi group compared to 22.9 units in the BIASP 30 arm, resulting in an LS mean difference of 12.2 units. So clearly less total insulin dose was needed in the iglor-lixi group. Reduced incidence of hypoglycemia, which is again very important in terms of safety and patient outcomes over the 26-week treatment period with iglor-lixi versus BIASP 30. Incidence of anytime hypoglycemia, any hypoglycemic event The incidence was 31.2% in the iGLAR-LIC-C group versus 42.4% in the bias 30R group. ADA level 1 hypoglycemia less than 70 and more than 54 milligram per deciliter. The incidence was 25.8% in the iGLAR-LIC-C group versus 38.5% in the bias 30 group. ADA level 2 hypoglycemia was 6.3% in the iGLAR-LIC-C group versus 12.9% in the bias 30 group. Relative odds reduction, 38% of any hypoglycemic event in the iGLAR-LIC-C group, ADA level 1 hypoglycemia, 45% reduction in the iGLAR-LIC-C group, and ADA level 2 hypoglycemia, 55% relative odds reduction was seen in the iGLAR-LIC-C group. So conclusion, iGLAR-LIC-C demonstrated lower incidence of any ADA level 1 and ADA level 2 hypoglycemia compared with bias 30. Only 3 ADA level 3 hypoglycemic episodes were reported, 1 in the iGLAR-LIC-C group and 2 in the bias 30 group. Reduced rate of hypoglycemia was seen in the iGLAR-LIC-C group, ADA level 1 and ADA level 2, compared with bias 30. There was 33% relative rate reduction with iGLAR-LIC-C versus bias 30 in terms of any hypoglycemic event. ADA level 1 hypoglycemia, 29% relative rate reduction with iGLAR-LIC-C group versus bias 30 group. ADA level 2 hypoglycemia, 60% relative risk reduction with iGLAR-LIC-C versus bias 30 group. So the Solimix study looked at the nocturnal hypoglycemia as in a post hoc analysis endpoint. Nocturnal hypoglycemia, as we all know, is very important. 2 nocturnal hypoglycemia intervals were utilized for the Solimix trial. Between bedtime and waking, more representative of clinical practice, as we all know, between midnight and 6 a.m., often used in randomized controlled trials as reducers confounders. Hypoglycemia endpoints, ADA level 1 less than 70 and more than 54, ADA level 2 less than 54, ADA level 3 severe. ADA level 1 hypoglycemia, we can clearly see incidence of ADA level 1 hypoglycemia was lower with iGLAR-LIC-C versus bias 30 between midnight and 6 a.m. and was similar between bedtime and waking. And you can clearly see the lower incidence of level A hypoglycemia between midnight and 6 hours with line of unity moving in favor of iGLAR-LIC-C. Incidence of ADA level 2 hypoglycemia was lower with iGLAR-LIC-C versus bias 30 for both nocturnal hypoglycemia intervals. You can clearly see the endpoint moving away from the line of unity in favor of iGLAR-LIC-C during the both nocturnal intervals between bedtime and waking and between midnight and 6 hours. Key results in terms of efficacy. Compared with bias 30, iGLAR-LIC-C demonstrated non-inferiority of HbA1c reduction, superiority of HbA1c reduction, superiority of body weight change, greater proportions of participants achieving HbA1c less than 7% without weight gain and without weight gain and hypoglycemia. Benefits observed with iGLAR-LIC-C were accompanied by a smaller mean daily insulin dose at week 26 in the iGLAR-LIC-C group compared with bias 30. In terms of safety, rates and incidence of hypoglycemia were lower for iGLAR-LIC-C than bias 30. Proportion of participants with adverse events was slightly higher with iGLAR-LIC-C, basically the GI intolerance, than bias 30 due to higher incidence of GI adverse events. Serious adverse events and study discontinuations due to an adverse event were low and similar for both arms. The overall safety and tolerability profile of iGLAR-LIC-C and bias 30 were comparable with those reported in previous studies. No unexpected safety signals were identified. Conclusion, result from this first trial comparing a fixed ratio combination of basal insulin and GLP-1 receptor agonist iglorlixi with a premixed insulin by ASP30 provide evidence for the better efficacy and safety of iglorlixi with a simpler regimen compared with premixed by ASP30 in adults with type 2 diabetes advancing their treatment from basal insulin plus 1 or 2 oral anti-diabetic drugs. Iglorlixi may facilitate optimal advancement of therapy in people inadequately controlled on basal insulins by providing better glycemic control with weight benefit and less hypoglycemia than with premix by ASP30. Thank you for your kind attention.